introducing our three panelists today, and then I'm going to start by presenting my own personal case of a mistake that I made relatively recently, and I'm going to try to get people's opinion about what they think they could have done to avoid the mistake. So with us today is Dr. Charles Argoff, who's professor of neurology at the Albany Medical College and director of the Comprehensive Pain Management Center at Albany Medical Center in Albany, New York. He's a neurologist who specializes in pain medicine, predominantly treating patients with chronic and neuropathic pain. Also with us today is my colleague, Dr. Mitch Harris, who's the chief of orthopedic trauma at the Brigham Women's Hospital in Boston, professor of orthopedic at Harvard Medical School. His special interests include spinal tumors, arthritis, and trauma, as well as periarticular fractures and infections of bone. And also with us is Dr. Zachariah Isaac, who's medical director of the Brigham Women's Multidisciplinary Spine Center and instructor at Harvard Medical School's Department of Physical Medicine and Rehab. His clinical interests include non-operative management of spine disorders and interventional spine procedures. So you have an opportunity here to basically sit together with a group of experts and think about some important problems in low back pain and related spine disorders. So welcome to all of you, and thanks very much for taking the time to join us this evening. Let me start by presenting my case. The idea here, of course, is to present our own errors. Everybody here is aware of the error phenomenon that began in 1999 when the Institute of Medicine published its landmark study called To Err is Human, and that has created a real culture of error prevention in medicine. And only recently, I would say, that people are become willing to really present their own mistakes to try to analyze the source of those mistakes and how they can best avoid them. So let me start by presenting a case to you all. Then I want to turn to each of you and ask you what your take is on the case and what you would think about it. So this is a patient, actually, this occurred to me just this past week. So it's a very recent experience of my own. 48-year-old right-handed woman with a history of connective tissue disorder who had a long history of aches and pains, joint pain, and low back pain, but came to us just last week complaining of what she called a different and much more severe pain, which she told us emanated from a slightly higher level than she was used to, higher than her usual lower lumbar spine, and had a tendency to radiate around the flanks toward the umbilicus. She woke in the morning with pain. She told us that she was shoveling snow the evening before, but didn't have any acute pain while she was shoveling snow. She went to sleep feeling well, woke up with this severe and memorable pain in her back. She said that her bladder seemed what she called a little more urgent than before, but she said she could feel a full bladder and she could empty it completely. She was chronically constipated, according to her, and she said that this phenomenon had not changed with the onset of this back pain. And then over the past 3 days, just before her coming with us to see us, she developed leg weakness to the point where when she actually arrived in the emergency department, she could no longer stand or walk. So that was the history. Do any of you want to comment about the history before I tell you what we found on the physical examination? What do you think about this case?
Dr. Arga? I think he's having connectivity issues as well, but if you want to move on to one of the others.
More than the usual sort of low back pain story.
Dr. Isaac?
I'm sorry, there's a little bit of voice cutting in and out earlier. The question is, what did I think about the story?
Yeah, what do you think about that history?
Certainly sounds more concerning than the typical back pain flare, in that there's thoracic symptoms, there's neurological weakness, there's some bladder symptoms, and maybe some chronic bowel symptomatology. So certainly more concerning than your typical back pain, axial back pain flare of musculoskeletal etiology.
Mitch, what is your reaction to this story? She was shoveling snow the night before. She didn't really feel any pain. Woke up with this memorable back pain, a little higher than she was used to from her sort of chronic backache. Is there anything we should be looking for here?
Well, aside from what Dr. Isaac just mentioned about the neurologic story, usually when I hear that, I put it on in the back of my mind and do a very thorough exam, because oftentimes pain can lead to a lot of these inabilities to walk or urgency with urine. So my first thought in this particular case is to do a very thorough exam.
Right. So let me tell you what I found, and I examined fairly carefully, and see what you think about this exam. She had what I thought was full range of motion of her back. She could bend over and twist, and without any particular additional pain. And in particular, there was no percussion tenderness of her back, so I pounded on her spine. There was no pain. I even listened with my stethoscope for what it's worth. Didn't hear any bruise over the spine. Her mental state was normal, and her cranial nerve examination was completely normal in all respects. But her motor exam was dramatically abnormal. She had severe proximal weakness of both legs. In fact, I would say that her power in the flexors of the hips, in the iliopsoas, was traced. She had 1 out of 5. She could barely move the limb. She didn't really move it at all, and certainly not against gravity. Distally, she was much better. And actually, in the feet, I thought she was virtually normal, although she had a subjective tingling sensation in both feet, but she couldn't describe any further than that. And then she had a sensory abnormality, and I thought that there was a sensory level on the trunk at about T10 that I found on the back. So I went up and down her back very carefully, and I looked for an autonomic level and also a sensory level, and it wasn't sharp or definite, but she said there was a change at about T10. She had no Bivor sign. Just to remind the listeners, this is a sign of weakness of the lower quadrants of the abdomen, at least that are around T10. So when she tried to sit up, I didn't see her umbilicus move upward as if there was weakness of the 2 lower quadrants. She couldn't stand at all because of this proximal weakness. And strikingly, all of her reflexes were absent. I couldn't elicit any reflexes either in her upper extremity or lower extremities. And her plantar responses, I would say, were equivocal. I must say that I try not to say equivocal, but I couldn't be certain about them. I thought that her toes might be up, but they weren't. They certainly were not the most florid signs I've ever seen. So I wonder if I can turn it back to you at this point and see what you think based on the findings. You have to sort of assume that what I told you was correct. What do you think is going on here? Are you willing to take a shot at this?
Dr. Isaac.
So so far the story sounds like the abrupt onset of pain after shoveling may be a little bit misleading. That abrupt onset would lead one to think perhaps they herniated a disc or had if they were osteoporotic, there was a compression fracture. But the neurological examination is not compatible with those diagnoses, given that the patient has largely preserved distal strength, but predominantly bilateral proximal weakness. And additionally, given the pain-free lumbar range of motion, I think it would make the typical degenerative causes of pain and musculoskeletal causes much less likely at this point in time. Proximal weakness is not a common presentation of disc herniations or other typical spine degenerative causes.
And Mitch, are you also concerned about this patient, as I was when I saw her?
I'm certainly concerned by your story and by your examination, but what I find is if you have an acute injury to your back, testing the hip flexors is often a bit misleading because the psoas muscle inserts on the transverse processes. So if I'm looking for the proximal lumbar roots, as far as their weakness, I'll try to eliminate their insertion in the spine and test something like the adductors to get a comparable test on something that's not definitively attached to the spine. So I'm with Zach. I think there's something a little bit awry in this story, particularly with an intact distal sensory and motor exam.
Yeah, I was very worried about her, and I thought it was a myelopathy, a spinal cord disease, and in actual fact, what I predicted it would be was a longitudinal, extensive demyelinating process in the spinal cord related to that mixed connective tissue disease. And as everybody knows, these patients can develop something that is sort of MS-oid. They get these long lesions in the spinal cord. And I thought that that's what this was going to be. I also considered the possibility of a fibrocartilaginous embolism. I wonder what you think of that as a possibility, Zach. What do you think about a fibrocartilaginous embolism? A few hours or maybe a day after some physical exercise and then a myelopathy.
It's not a diagnosis that I've made. I'm not that familiar with that entity, and I wouldn't know that I would be able to pick that up.
So anyhow, we decided we better image the spinal cord, and I think if we put that image of the spinal cord up, can everybody see that all right? What I've shown you here is a representative image of the sagittal cord, and you can see that there's no compression at any level of any sort, but there is a little tiny white lesion at T7 through T9, which is intramedullary inside the spinal cord, which is interpreted by the neuroradiologist as probably a tiny little syrinx, probably not important or relevant in the situation. And of course, her reflexes were absent. They were absent in the legs and the arms. So needless to say, a lesion at T7 through T9 wouldn't explain this. So I wonder if anybody of our panel of experts would know what to do next, or would suggest how I could help myself in this case, because I clearly was not correct. And not a longitudinally extensive demyelinating lesion in the spinal cord. So what could it be?
I have some concern that you had stated earlier. You had stated that the patient was largely areflexic, and I was wondering, in that context, why were you suspecting a myelopathy as opposed to some other lower motor neuron process or other neuromuscular disorder?
Yeah, funny thing, I showed you how you can make these kinds of mistakes. In taking the history from her, I immediately thought to myself that it might be a myelopathy, and I thought I found a level on the trunk. I found the areflexia. I actually didn't know what to do with it, and wasn't sure that maybe she'd been that way all along. What actually was done next, just to sort of finish this case and then turn to the rest of it to see what other kind of errors cases you could present to us, was that the spinal fluid was looked at, and the protein was 90, which is very elevated. There were no cells in the spinal fluid, and consideration of Guillain-Barré came up. So she had an EMG, nerve conduction test, and in fact, that's exactly what she had. She had a post-infectious polyradiculopathy, and it's interesting to try to remind ourselves of how often pain in the back and the flanks is part of the initial presentation of Guillain-Barré. This patient then went on to become a clear Guillain-Barré, weak in all four limbs, no reflexes, with an abnormal nerve conduction test. She was treated with intravenous immunoglobulin, and she's gradually been improving over the period of the past week or so. So this was somebody who presented with a severe back pain, who I sort of misinterpreted as a myelopathy, which turned out to be a polyradiculopathy. So it's I thought it was quite a challenging case.
Zach, are you there?
Who are you talking to?
Zach.
This is Zach, yes. I can barely hear you.
All right.
I can hear Kelly. I can't hear who was speaking earlier.
Okay, so it's your case up.
Okay. Do you have the images of the case that I have available?
Yep, the first one's up.
So, okay.
And you can move through those, or I will.
Okay, so I had a 58-year-old woman with a history of a congenital hip dysplasia and fibromyalgia who actually came in with back and bilateral hip girdle pain. She was asked to be evaluated with me by orthopedics, and the patient had chronic discomfort but had particularly worsening discomfort over the past 3 months without any specific trauma. Now, the patients had multiple trials of medications, including Tylenol 3 and NSAIDs, and didn't make much progress. The patient had imaging of her hips, which didn't show much in the terms of arthritis. Imaging of the spine showed some nonspecific degenerative changes of the disc and facet joints, but overall fairly mild. The patient had because of the painful hip range of motion on the right side, the patient had an intra-articular hip injection, and the intra-articular hip injection was negative, so she was referred to spine service thinking that her back and hip girdle pain was not hip-related and rather was back-related. She was evaluated by our spine service, and on exam, the patient had intact strength, pain-free lumbar range of motion, preserved sensation, but the main predominant thing was right hip girdle range of motion with internal rotation and external rotation caused groin pain, which is more typical of hip arthritis. But the main thing leading them away from back versus hip as a diagnostic dilemma was that the diagnostic block of the right hip did not relieve the patient's pain. Are there any questions that the panelists have about exam or history at this point?
Could you reproduce her pain, Zach?
So I could reproduce her groin pain with external rotation of the hip, more so than internal rotation of the hip, and I could produce significant anterior groin pain with that. But lumbar range of motion was relatively pain-free.
And what about resisted hip flexion?
Resisted hip flexion was painful and caused apprehension in the groin, but most hip provocative maneuvers also created some lumbar pain as well as groin and gluteal pain. So the issue then was that the patient at that point was seeking our help regarding a spine condition as referred originally. And on examination, on further review of her bony MRI of her pelvis, and that's what I have up right now, is a condition called ephemeral impingement, which in patients with certain types of congenital hip dysplasia can have impingement of both the ischium and the femur. And this creates a significant bursitis and tendinitis, and this can manifest with both back pain, gluteal pain, and groin pain. And what seemed to have misled the referring docs was that they relied on the intra-articular block of the hip as an exclusion of this being a hip problem. But this issue is a soft tissue issue around the hip, and diagnostically anesthetizing and injecting steroid intraarticularly would not affect this area. So a diagnostic block actually misled diagnosis in this case away from the hip and to the back. And to me, this case illustrates how back and hip girdle disorders can often mimic each other and create diagnostic dilemmas and misinterpretation.
I think that's a very, very interesting one. It's a common issue that we face to trying to decide whether somebody has, whether the main problem is hip or back. And I think that's really a very, very interesting example. Mitch, do you have something that you would like to present to us? Maybe a quick one. We're coming to the end of our half hour.
I'm happy to do that unless you want to start taking some questions at this point. Well, I'll tell you, I run a spine service. I have a spine practice, and very commonly see the walking wounded of the young and some of the older individuals that have degenerative arthritis and or symptoms of spinal stenosis. And I was reminded just recently of how important it is to put together the history, the exam, as well as the studies. I had a gentleman who was a poor historian, but escorted by his son, tell me how he had been progressively losing the ability to walk long distances. He felt better leaning forward, and in fact had classic signs and symptoms of neurogenic claudication. Because of his pacemaker, he was only able to undergo a CT myelogram as opposed to a more standard MRI examination. And during the CT myelogram, it showed fairly classic stenosis at 3, 4, and 4, 5. So feeling pretty comfortable with that, I was discussing with the family the concept of doing a spinal decompression procedure. The son was very clear that back pain was really a very major component of this, so I went back and looked at his CT myelogram more closely to find that he also had some areas of sclerotic bone that at first glance I thought were from his degenerative process, but the more I looked at him, the more it became obvious to me and the radiologist that this was something that needed further workup, and in fact, long story short, were prostate mets to his lumbar spine. So again, the importance of fitting together not only a history and an exam, but also good radiographic studies before you step down the path of diagnoses.
That's very interesting, Mitch. Zach, do you have any reaction to that, Kate?
It's certainly frustrating when patients present with typical degenerative things and common things being common. You think of the degenerative causes, and we've all been fooled starting off with a presentation of a degenerative condition and then discovering that the recurrence of issues or the new evolving issues are representative of a medical pathology.
Zach, when we were preparing for this webinar, we had some questions from people who were planning to participate. And one of them was whether there's any effective therapy, lumbar stenosis, medical therapy. What would be your reaction to that question?
So I think that the studies demonstrate that the most effective treatment for lumbar stenosis is surgical. I think that there is some limitations, however, in the fact that many patients that have stenosis also have concomitant hip pathology or a significant portion of axial back pain rather than leg pseudoclaudication symptomatology. There are a fair number of patients that are elderly and do not want to undergo the risk of surgical intervention. And many patients, frankly, don't want to start off with a surgical intervention, even if it might be ultimately the best treatment option. So I think that medical therapy has a role because supportive care and the proper use of exercise and analgesic medications and at times injection therapy can help improve symptoms and help them manage. I think there's a threshold at which patients are failing to respond adequately and feel that their quality of life is impaired enough that they wish to take that next step and undergo surgery. And I think that's an important step to make if they get to that point. I think that many patients, however, need information. They need to be treated comprehensively and at least attempt sound conservative therapies initially.
That's great. One last question, maybe, because we're a little bit over our time, and I just a number of people who wrote in advance about this were the main issue was isn't there too much imaging of people with back pain, and some general guidelines as to how to decide who to image and who not to image. My own reaction as a neurologist is a lot of it depends on the neurological examination and the history. That if you feel as though there's a structural lesion in the CNS, like the case I presented, which happened to be a peripheral nervous system case, that then you might image. But just imaging people with low back pain is probably not very cost effective. What would you say about that, Mitch and Zach? What are sort of the final comments for our little conference today?
Well, I think that a lot of times that the primary care physician is put in a very awkward position in that he or she is evaluating somebody for a spinal condition, and when they exhaust the first line, whether it's therapy or therapy and anti-inflammatories, they'd like to get a second opinion or a more centered opinion by a spine physician. And increasingly, spine physicians prefer to see patients only after they've had an MRI. And I think that's one of the reasons that we're seeing so many excessive studies performed, because it's a method to get into a physician's office. And I think we need to, be more aware of this and allow these patients to be seen without having to go through an MRI prior to their evaluation.
Zach, any final remarks as we come to the end of our time together?
Yeah, I think it's very difficult because a fair number of patients go on with chronic symptoms without a neurological abnormality. And I think that the way I usually put it to my patient is that if you're having persistent symptoms, but we do not think that this is of infectious etiology, and it is likely of degenerative etiology given the lack of any concerning clinical red flags, us knowing the exact defined anatomy isn't necessary unless you're at the point that you want to consider surgical intervention or injection therapy. So if you put it to that point that these are the advantages of getting imaging studies is only when you need to act on the specific anatomy, many patients are okay with holding off on invasive therapies until it's necessary. If you do have concerns about medical infectious etiologies or malignant etiologies, then imaging, or neurological problems, then imaging should be pursued.
So the final thing I would say about it is that one of the dangers of too much imaging is not just the expense, but the incidental loma problem. As you saw in my case, the finding of this little syrinx, and had we not been able to think carefully about that, you can imagine that somebody would have tried to do something to drain that syrinx, and that syrinx had nothing to do with the clinical case, which was actually a completely peripheral phenomenon. So I think we're coming to the end of our time together. Eric, do you want to make any final remarks before we close out for the evening?
Sure. Thanks, Dr. Samuels. Just a quick reminder to everyone on the call that if you want to request that half a CME credit, just to quickly take this 2-minute survey that's in front of you, it allows us to you the opportunity to request information from all of us, while also asking for a little bit of your feedback on what we could provide as far as content and subjects moving throughout the year. I want to thank our panelists for doing a terrific job and for taking the time to participate today, and thank all of you as well. We know your time is really valuable, and it's fairly late in the evening here on the East Coast. So thank you all for taking the time. Thank you all for bearing with our audio technical difficulties at the beginning. And Marty, a special thank you to you. Thank you very much for moderating. You did a tremendous job. So this will mark the
my colleagues, and good night.
Yeah, good night, everyone. Thank you.
Thank you.
Thank you very much.
Thank you.